ahead and get started. Hello, everyone, and welcome to Caring and Living as Neighbors parallel event at the 64th Commission for the Social Development with the United Nations. My name is Tara. I am a second-year university student studying population health and biostatistics at Lehigh University in Bethlehem, Pennsylvania, and I'm co-hosting this event with my fellow UN Youth Representative, Samiha.
Hello, everyone. My name is Samiha Asthma. I am also a second-year student at Lehigh University studying neuroscience and sociology. I'm also UN Youth Representative for CLAN, and I'm co-hosting this event alongside my partner, Tara. Please ensure that you're muted if you're dialing in virtually. This event will be recorded and posted with a report soon on the CLAN and Meets for Kids websites.
Before we start the event, we would like to acknowledge the traditional owners of the lands that everyone is dialing in from virtually. We invite you to post the traditional lands that you are in the chat right now. From Lehigh University in Bethlehem, Pennsylvania of the United States, I acknowledge I am representing the lands of the Lenape people, and I pay respect for elders past, present, and emerging. As CLAN is based in Australia, we acknowledge the traditional owners of country throughout Australia and recognize their continuing connection to land, waters, and communities. We pay our respect to First Nations peoples internationally and to their cultures and elders past, present, and in the future.
This event is in partnership with the Lehigh University United Nations Youth Representative Program. The Lehigh Youth Representative Program was established in 2008, and it matches high-achieving Lehigh students with UN-accredited NGOs. CLAN is one of 13 NGOs that are Lehigh's partners and one of the strongest partners that Lehigh has. CLAN currently has 2 UN Youth Representatives, Tara Chelbam and Samiha Islam, myself, who advocate for CLAN at United Nations events such as this one. This program allows youth to have a voice in global matters, and in our case, advocacy for children who are living with non-communicable diseases in resource-poor settings.
The focus of the 64th session of the Commission for Social Development is to promote social policies that support the UN's overall development goals. The priority theme for this event is advancing social development and social justice through coordinated, equitable, and inclusive policies. In this presentation, our speakers will highlight the importance of SDGs 1, 3, 10, 16, and 17, among many others.
Our event focuses on non-communicable diseases, otherwise known as chronic diseases or NCDs. NCDs, unlike infectious diseases, are long-term or lifelong health conditions that cannot be transferred from person to person. They can be a result of factors such as environmental stressors and genetic inheritance. Some examples of NCDs you may have heard of include cancer, diabetes, sickle cell disease, and congenital adrenal hyperplasia. Many NCDs can be detected via newborn screening, which includes tests such as pulse oximetry tests and prick blood tests. Many NCDs are diagnosable and treatable. However, many economic and social factors can increase preventable morbidity and mortality of children living with NCDs. Therefore, our presenters seek to advocate for education and resources for NCDs to leave no child behind. Now, I'd like to introduce you to CLAN. CLAN, short for Caring and Living as Neighbours, is an Australian non-governmental organization founded in 2004 by Dr. Kate Armstrong. CLAN is committed to equity for children living with chronic health conditions in resource-poor settings. CLAN's strategic framework for action focuses on a multi-sectoral action on 5 pillars, which include 1, affordable access to medication and equipment, education of the individuals, families, communities, health professionals, policymakers, and the international community. 3rd, optimization of medical management, including primary, secondary, and tertiary prevention with a biopsychosocial focus. 4th, encouragement of family support networks. And lastly, by reducing the financial burdens on families that lead to poverty, we help people become financially independent, enabling them to provide the necessary healthcare for the children in the long term. Plan is focused on promoting equitable access to newborn screening services for all children in the world, as it supports the early diagnosis and treatment of many chronic health conditions. A rights-based approach is at the core of Plan's mission to support children with non-communicable diseases and other chronic health conditions. This approach recognizes that all children, regardless of their health status, have the right to the highest attainable standard of health as outlined in the United Nations Conventions on the Rights of the Child and other human rights frameworks.
I'd now like to introduce Dr. Kate Armstrong.
Thank you so much, Tara and Samia, for your great work and for everything that you've done behind the scenes to make this event possible. And thank you to everyone for joining at different time zones around the world. I'll just give a few brief comments before we start today's event and just acknowledge everybody who's been part of the Mates for Kids network, maximising access to essential supplies for children. We came together as a network in 2021, committed to reducing the preventable mortality associated with one particular childhood NCD, congenital adrenal hyperplasia, by 30% by 2030. And we did this to align with SDG 3.4 as much as we could. And we felt that it was really possible to achieve this through three key objectives: improving access to essential medicines, hydrocortisone and fludrocortisone for children with CAH, strengthening CAH communities, and scaling access to newborn screening. It's this real passion for access to medicines, and if you could go to the next slides, please, Tara and Samia, that really unites us all. And we're very mindful that it's not just children with CAH who need access to essential medicines, but it's all children with chronic health conditions. And CLAN was founded in 2004, and we've just been listening to childhood NCD communities for over 20 years, talking about how desperately they need access to essential medicines and technologies. And so the political declaration that came out of the 4th UN high-level meeting on NCDs and mental health, it was passed in December last year, was just really encouraging. The target says that we'd aim for at least 80% of primary healthcare facilities in all countries to have availability of World Health Organization recommended essential medicines and basic technologies for non-communicable diseases and mental health conditions at affordable prices by 2030. So this is really a very bold goal. So today we're going to listen to champions from some key childhood NCD communities talk from their perspective of how they feel we're tracking to this 80% by 2030 target. We'll be hearing from people from asthma, type 1 diabetes, adrenal insufficiency, sickle cell and childhood cancer communities. But we're also very mindful that there are so many others communities who, by rights, there are medicines and technologies on the EMLc, the Essential Medicines List for Children, but they need access to epilepsy, rheumatic heart disease. There are bacillin shortages all the time, osteogenesis imperfecta, congenital hypothyroidism, the list goes on. So by the end of today, we hope to have some reflections and recommendations that we can put into a report that help us all to think about where are we going to now and what are the next steps that we need. So with that, I'll hand back to Tara and Samia. Thank you.
Thank you so much, Kate. I'd now like to introduce Katia de Pinho Campos and Rodrigo Cataldi.
Thanks very much, Tara. Can you hear me well? Yes, okay, good. Thank you for inviting WHO to be part of this webinar. It's a great pleasure to connect with all of you, and congratulations to Clan, Kate, and Tara and colleagues for organizing and moving this agenda and pushing this agenda through a very well-connected group of stakeholders, civil society. I'm here with my colleague Rodrigo Cataldi. We're going to be splitting our presentation. I'm going to talk more about our work in the GCM, the Global Coordination Mechanism on NCDs, which CLAM is part, is a member of this mechanism, as well as Rodrigo. We're going to focus more on the work that WHO is doing in developing an operational framework for access to medicines. So next slide. So next slide, this is our agenda. We will try to cover this as quick as possible. Just for those who don't know us, who don't know the Global Coordination Mechanism, NCDs, we were established by member states in 2014 as a mechanism to bring together civil society organizations, people living with NCDs, academia, the private sector, to really discuss and strengthen the governance of the NCD and support governments to advance the agenda of NCDs at their own countries. The Global Coordination Mechanism, we call GCM, has evolved throughout the years. And we are now very much focused on continue strengthening NCD governments, but we have a normative and leadership component in that area, but also we function as a secretary of the mechanism where we have the civil society, and I will explain to you in the next slides or so, the civil society organizations working with us very closely for us to move and support member states in advancing the agenda. And we do this through two important pillars, what we call multi-sectoral action, which is for us, multi-sector is the collaboration, the NCD governance across different ministries, different government sectors. And the multi-stakeholder engagement where involve civil society, involve people living with, involve academia and private sector. So we look at the NCD governments through those two lenses, but also we promote, connect, facilitate the knowledge transfer and dissemination and collaboration among those stakeholders. So we work with stakeholders to really promote, disseminate, and expand this the information, the lessons learned, the promised practices, and the connections between them to strengthen their work in the country. Next slide. Now the political declaration Kate already mentioned. Next slide. There are two important aspects that I would like to highlight here because it has to do with our presentation, has to do with the work that we are doing. The political declaration, besides the targets that Kate mentioned, they reaffirm the importance of pursuing whole of government and whole of society approaches. This is what I just said, is another way to say whole of government is the multi-sectoral collaboration, is the collaboration across different government sectors, different ministries. And whole of society is really to bring those stakeholders, CLAM, university, other civil society, lived experience, private sectors together to really advance, implement, and support member states in the agenda of NCDs. So the political declaration reaffirms of the importance of their role in implementing the targets. Next slide, please. And also, as I said here, and also goals recognize that to achieve NCD goals, we need to go beyond the health sector. And that is why it's so important to connect, to engage, and to develop a multi-sector policies to really promote, accelerate cost-effective interventions for NCDs. Next slide, please. So, let me just explain what we are doing in those two areas, multi-sector governance and multi-stakeholder engagement, and then I will pass the floor to my colleague Rodrigo, who presents the WHO operational framework. Next slide. So some highlights of what we do, next slide, in the multi-sector government aspects. We have developed a guiding framework that has helped us to map what are the multi-sector actions that member states are doing to strengthen prevention and control of NCDs. We have collected 95 country experience from 45 countries, and we have digging and to understand a little bit more what are the bottlenecks, what are the gaps, what are the opportunities, and what are the lessons learned that we can take from those experiences. And we developed 17 case studies that has helped us to really get to a set of key elements that are important for member states to advance the agenda of multi-sector action. For example, institutionalize multi-sectoral national court mechanism was one of the lessons learned from the analysis of these stakeholders of this case study. So we have this report. You can access the report and all our resources through the QR code that you have in the slides in front of you. So this are some normative guidance that we develop in that particular area. Those are examples of guidance that we do. So we work on normative guidance, but also we do global leadership and global advocacy, because we connect with our stakeholders to really augment the message, the narratives, and the opportunities for multi-sector engagement. We have done this through different thematic areas, publication. We have a commentary about ADG. So we try to identify opportunities that we can advance the message in the narratives and doing a more evidence-based global advocacy. And we are now going to a more in-depth project in countries, for example, in Ghana and Sri Lanka. We're going to deep dive in those countries to understand what are the bottlenecks that government is facing to really advance the multi-sector policies that would help them to achieve the targets in their programs and strategies. Next slide. The other pillar of the GCM is the multi-stakeholder engagement, as I mentioned. In the multi-stakeholder engagement, we have different approaches and we work with different constituencies. As I said, one constituency, for example, is the lived experience. WHO developed the first WHO framework of meaningful engagement with people living with NCDs and mental health conditions. And this framework has guided not only WHO, not only ourselves, our technical units, but also member states in how they have to engage lived experience and experts with their expertise to develop policies, to be part of decision making. In fact, to support implementation of programs, so be part of the response of the governance of these policies. We have developed several publications, and also one particular interesting tool is the decision-making tool. And this decision-making tool was developed for member states to guide their decision on whether or not to engage with the private sector, particularly because in the area of NCD, we have a lot of potential sensitivities with the private sector. So member states using this tool can make an informed decision about conflict of interest, about risk, about opportunities and benefits. Another important component, and this is really where CLAN sits in, is like the engagement strategy with the civil society and our GCN's participants. We have over 60 organizations, not-for-profit organizations or civil society organizations that are members formally accepted to be part of the GCM, and they support us moving the agenda forward. And we work together, we develop projects together, and we support governments in engaging with civil society for them to move the agenda in their country. Next slide. And then we have, please access our knowledge action portal. You can find many information, resources, not only from WHO, but also from our civil society organizations, our GCN's participants, CLAM, for example. This is a platform that we engage the community. We support the community to share, to promote knowledge, and to connect. We have 1,000+ resources available to everyone, different language. So please connect with the Knowledge Action Portal, subscribe, and you're going to be part of this community to engage and to expand the message that we always want to strengthen the role of civil society. Now I think, Rodrigo, I'll pass to you. Thank you.
Thanks a lot, Katia, and thanks everyone for listening to our presentation. I'll briefly discuss ongoing work that WHO is doing around the operational framework to improve access to essential medicines and related health technologies for NCDs. And as you, can you just go back for 1 second? Sorry. Historically, we have looked and we had the understanding, and everyone has the understanding, that medicines, to be accessible, they need to be available and affordable to people. And this is still true. And what we are trying to address and understand is what is behind health systems and beyond health systems that make medicines available and affordable in countries. So WHO has an entire division on supporting countries and member states to improve access to medicines and related health technologies, diagnostics, and so on. And this, we are looking in our department specifically on improving access to NCDs. Next slide, please. And through this activity, the objective of the operational framework is to provide a clear strategy, identifying the different challenges that countries face towards access to NCD medicines, and which are the actions required in these different countries to address this need of the population living with NCDs. But the operational framework will also serve as a coordination mechanism to guide not only member states, but all relevant international partners, pharmaceutical companies, to work towards the same goal. There is a lot of great work being done to improve access, and it's important that we are connected, that we are collaborating, and we are aligned in our activities. Next slide, please. So the operational framework focuses on diabetes, hypertension, dyslipidemia, chronic respiratory diseases, and some types of cancers that can be addressed either as prevention or pain management at the primary care level. So we know that most of the populations, they access the first point of care of the population is at primary care. So addressing these issues at the first contact is really essential to make sure that people have access to the treatment that they need. Next slide, please. And even though we are using these conditions as tracer conditions, actions associated to these conditions and to improve access to medicines to these conditions, they will build capacity across the health system to make sure that all the conditions that are not among the tracer conditions have also improved access. And this work is being guided by a WHO roadmap to improve access to safe, effective, and quality assured health products and technologies. So that includes medicines. And we are working under the umbrella of this roadmap that is initially disease agnostic, focusing now on NCDs. And when I was talking in the beginning about what makes medicines available and affordable so people can have access, you can look at these different components of the health system and beyond that make medicines available and affordable. So we can be looking specifically in the health system, the procurement and supply chain management, regulatory systems, how the country selects and prioritizes some conditions. But even if medicines are available and affordable in countries, it's also very important that the workforce is qualified and trained to diagnose and provide a care to the patients. So that's why the health workforce, service delivery, everything is encompassed in this approach of WHO that we are now focusing on NCDs. Next slide, please. So this work has started. We started to look at cross-cutting issues, for example, procurement and supply chain. But supply chain can be cross-cutting, but can also be disease-specific. For example, a cold chain to improve supply of insulin. It's different than considering oral medication. So we have this cross-cutting approach, but also disease-specific, identifying the challenges and what is known as a solution to address these challenges. So these have been identified through scoping reviews, both on the great literature, published literature. Next slide, please. And will be supplemented through multiple stakeholders consultation. So that includes civil society, that includes experts from the different areas, people living with NCDs and others. We are at that stage now where the scoping review has been completed. We'll run our consultations in the next few months, and we'll work together with the experts to finalize the document, which is the first step, because then the work starts, which is really implementing the operational framework and supporting countries to improve access. Next slide, please. Yes, so this is the stage that we are now, and we are working very hard to start implementing the operational framework as soon as possible. Back to you, Katya.
Thanks very much, Rodrigo. And we're going to be supporting Rodrigo's team to develop, to do the consultation with the live experience as well with civil society. So stay tuned and we will reconnect again. So my last slide here is what civil society, what is the role of civil society in all of this? And you have a huge role, and you are, the civil society is just as partners as can be to support moving NCD agenda, many other agenda, developing agenda, in particular this one that we are discussing here in terms of advocacy, in terms of engaging meaningfully live experience in communities to understand their barriers, to understand their needs, and to get the solutions from them as well. And also support the implementation, Rodrigo said, once the framework is developed, we really need to roll out and support member states and implement it. And civil society in many countries are there, the service delivery level, to support member states in doing that. So you have a huge role in this exercise. And this it's a challenge, it's ambitious, but we believe that together and with the driving force of the civil society, we can do this and be successful at the end of the day. Thank you very much for the invitation again. Really appreciate it, and good luck in the rest of the seminar. We are happy to support you moving along. Thank you.
Thank you so much, Katia and Rodrigo, for your presentation and for the meaningful work that you're doing. I would now like to introduce Leith Greenslade.
Thank you so much, Samiha. Okay, so I'm Leith Greenslade. I'm speaking today on behalf of the Forum of International Respiratory Societies, or FIRS. This is the largest global network of clinical experts in lung health, including asthma, and I'm delighted to be representing them. So let's talk about asthma, children with asthma. So next slide, please. There are 102 million children under 15 living with asthma. These are the very latest statistics from the Global Burden of Disease. That's a lot of children. In fact, asthma is one of the highest prevalence of NCDs among children. Where do they live? You can see they're spread across the world, but look at Africa. A quarter of those children are living in Africa, the Americas, and Western Pacific. Next slide. Children still die from asthma, 12,000 of them, according to the Global Burden of Disease. But look at where they die. More than half of those deaths, 53%, are in Africa. 17% in the Americas and 16% in the Western Pacific. But that burden in Africa really screams at you. Why are children, so many children, dying of asthma in Africa? Next slide. 70% of the deaths are in countries, specific countries. We thought it would be interesting to present this data. They're very clustered. 13 of those countries are African. 6 of them are Asian. And yes, the United States is on the list. So these are where 70% of those 12,000 deaths concentrate. Next slide. There are essential medicines on the list that help children manage their condition, stay out of hospital, and stay alive. The 10th WHO EML for children includes 2 of them. Budesonide, which is a steroid inhaler, which is preventive and controls the condition, and salbutamol, which is called a rescue or reliever inhaler if you have an emergency or an exacerbation. Children need both of these often. Note, though, there is a third category of medicine, a combination inhaler, which includes both. These are considered best practice, and they're not yet on the EML, but more about that later. Next slide. So who gets access to these inhalers that are already on the EML? So this is information from these wonderful NCD country capacity surveys that WHO produces. This is the latest one, 2023. Once again, showing what WHO calls a massive equity gap in access to inhalers. In fact, of all essential NCD medicines, WHO singles out the equity gap with access to inhalers. This is across low-income and high-income countries, as defined by the World Bank. We've got our bronchodilators, that's our salbutamol on the left. In the middle are the steroid inhalers, the budesonide and others, and then these combination inhalers, which are considered best practice. And I just want to draw your attention to the combination inhalers. 4% of low-income countries have those versus 80% of high-income countries. And even the gap for steroid inhalers is 36% versus 93%. So I've got a little quote there from the latest country capacity survey, which really calls out these massive equity gaps. Next slide. Let's take a look now at other studies, not WHO, but other studies confirm these wide gaps in access to inhalers. This is looking within a group of 60 low and middle income countries by pharmacies, hospitals, and central medical stores. Once again, we see very, very limited access. Now, this is just inhalers, if they're there. This doesn't mention affordability. So just looking at if the inhalers are there, we still see, apart from the bronchodilators, very limited access to steroid inhalers, which, let's remember, the steroid inhalers help you manage your condition and stay out of hospital, and these lovely new combination inhalers, which do both. And you've got a little quote there from this wonderful study that produced these results, showing that the numbers here, 10%, 6%, well below the 80%, which is the target we're all aiming for in access to these inhalers. Next slide. So what is FERS doing about it? FERS is leading a new campaign which was launched last year on World Asthma Day called Increasing Access to Inhalers, the first of its kind. And you can see on the left some of the leading clinicians. I think these are very, very well-known clinicians. Many of you will know their names. Professor Guy Marks, Professor David Halpin, and Professor Heather Czar. They've come together to lead this campaign for FERS, and there are 5 asks. You can see them lined up there. They all begin with P, the 5 Ps. They relate to policy, product, price, primary care, and patient advocacy. And FERS is calling on governments, industry, global health agencies, and donors to come together around these 5 priorities. Next slide. What has FERS done to date with the campaign? So FERS advocated very strongly for asthma language in the UN NCD political declaration, and they got it. So there on the right is clause 55, which mentions COPD and asthma. So they're incredibly pleased to have a statement within the political declaration that provides a foundation for action. They published a case study on Iman's story. This is little Iman. She's 6 years old. You can see a picture of her there with her mother. She lives in South Africa, and she really tells the story of what her life was like without access to inhalers, how much school she missed, how many times she's in the hospital, how much it cost the family, really to underscore the struggles children face when they can't get access to inhalers. We have a hot topics brief on spacers. So if you don't know what a spacer is, it's a little tool that goes on the front of the inhaler, which really helps children control the dosage. Spacers are really hard to get in many countries. So we need to raise awareness, not just about inhalers, but access to spacers. And FERS is calling for the inclusion of those combination inhalers I mentioned before, also called 2-in-1, on the WHO EML list for children. So I understand that will be open in around June this year. You'll be able to make submissions to strengthen the EML for children. Expect submissions from some members of FERS to try and get those combination inhalers onto the EML to strengthen it. Next slide. What's next? I just outlined some of that. So as well, WHO is updating the asthma management guidelines right now. We're very excited about this. Many of the FERS members are involved. So we should get a very, very strong set of new guidelines from WHO around asthma management, hopefully later this year. As I mentioned before, we're wanting to submit to add combination inhalers to the WHO EML. This year, we make the submission. And really excitingly, we're looking for partners to work together with FERS and governments on multi-country demonstration projects to do exactly what needs to be done to increase access to inhalers, to sort of show other countries how it can be done. And we're hoping to make progress on that this year. Next slide. This is the final slide. Join us. We would love to have you as members of the campaign. If you click on that QR code, it'll take you to the campaign website. We're producing new materials all the time. We're excited to join with other groups that want to increase access to medicines for children with NCDs. And we really thank Kate and the team for bringing us together and for leading on this agenda. We really look forward to more action together in the future. Thank you so much.
Thank you so much, Laith. This was a wonderful presentation. I'd now like to introduce Dr. Sawa Musa.
So, hello.
Hi.
Are you able to see my slides?
Yes, I will be presenting your slides on your behalf, so you can just tell me next slide.
Okay, so I'm sharing my slides, Tara. So if you allow me to share my slides.
Oh, okay.
Okay. Can you see my slides now?
Yes.
Okay. So hello everyone. I'm Salwa Musa. I'm pediatric endocrinologist and I'm the lead ASPI or African Society for Pediatric Endocrinology and Diabetes, CH and DSD focus group. So in the few minutes, I'll talk about the access to essential medicines for children with CH adrenal insufficiency in African countries, so I can share the update. So the outline would be the background, challenges in CH and adrenal insufficiency care in Africa, and then access to essential medicines for CH and adrenal insufficiency, and then to conclude. So when we think about the global child health, infectious disease often come to mind. But in reality, childhood NCDs like adrenal insufficiency and CH are silently taking lives. So adrenal insufficiency is a rare disease, especially in children, and CH is the most common etiology of adrenal insufficiency in children. Delayed recognition and treatment are associated with significant mortality risk. So at the fourth United Nations high-level meeting on NCDs, the member state committed to target at least 80% of primary healthcare facilities in all countries have availability of WHO recommended essential medicines and the basic technologies for NCDs and mental health condition at affordable price by 2030. But let's see if are we there yet. So Africa comprises 54 countries with multiple ethnic groups and varying degree of economic development. And there is lack of reports regarding access to medicines of CH and CA and adrenal insufficiency and similar conditions. So because of In God We Trust, all other must bring data, we are here to show the burden of CH and adrenal insufficiency in some African settings. This is some study from Sudan, where more than 400 cases of primary insufficiency have been detected. More than 80% are CH, and there is many challenges in diagnosis and management, especially medicines availability. So we conducted 2 surveys in different African countries to address the challenges in CH management and diagnosis. And actually what we realized that there is poor awareness about CH, and there is complex social dynamics in many African countries that prevent awareness about CH. There is no newborn screening program, no registry, no guidelines, and there is lack of diagnostic facilities and genetic testing. And there is also interrupted drug supply and adherence to medications, and also advocacy and lack of patient support groups. So one of the results of the survey that this is the cost of investigation and medication, and you can see here that compared to cost of investigation, the cost of medication looks very small, but yet it's not available. So let's see the challenges and access to medicine in different African countries. So we applied another survey to detect this access to medicine. to see if hydrocortisone and fludrocortisone available in different African countries, and where is the source of from which people get the supply, and what are the prices in different African countries in dollars, and do they use prednisolone as an alternative for hydrocortisone in different African settings. So we started with Egypt, where we can see with North Africa that 50% fludrocortisone is available 50% of the time and with low price, but hydrocortisone is not included in essential medication list and it's rarely available. Moving to Algeria in North Africa, hydrocortisone is available also in low price, but fludrocortisone is not available and they have to brought it from outside while prednisolone is available. Morocco, the hydrocortisone is available, but the fludrocortisone is not included in the essential medication list. In the Mali, the situation is not far better, where hydrocortisone is available but in private pharmacies, while fludrocortisone is not available, and when they can import it from outside, it counts around $170 for a bag. In Senegal, hydrocortisone is available also in private pharmacies, but fludrocortisone is not available and also it's imported from outside with higher prices. In Liberia, they got both hydrocortisone and fludrocortisone from private pharmacies, where in Abidjan, hydrocortisone is available, but sometimes it's not available, at which prednisolone is used. In Ghana, both hydrocortisone and fludrocortisone are not readily available, and when it is found, they are very expensive, and prednisolone is available as an alternative. In West Africa, Nigeria, the hydrocortisone costs $10 for 30 tablets, while fludrocortisone was $25 for 30 tablets. But because of the exchange rate and inflation, the 25 USD is significant for the average Nigerian family, as it's about the amount of minimum wage. In the Cameroon, hydrocortisone is available also in the private pharmacies, and the cheapest is $8 for 30 tablets of hydrocortisone, while fludrocortisone is not available. Moving down in Angola, the hydrocortisone is available in lower price, but the fludrocortisone is not available. But Botswana seems more lucky that both are available, but also there is problem in supply. In Zimbabwe, there is ongoing Catholic humanitarian donation for hydrocortisone and fludrocortisone for 3 years, but the wrong sustainable plan is not there. In Malawi, hydrocortisone is not always available, accessible, and affordable, but fludrocortisone is not available. In Uganda, both are found in the centers and it's not usually available, but there is educational training program for health professionals to promote early diagnosis of CH. But even when diagnosed, the management is not there. In Tanzania, it's not easy for CH patient to access hydrocortisone, and when it's available again, it's not affordable, and the condition is not that much better in Kenya, where both are available, but again, it's not always available, and when available, it's available in the private pharmacies. And also in Ethiopia, both are not available, and patients buy it from abroad. In Sudan, before the war, it was available 50% of the time for hydrocortisone, but fludrocortisone is not included in essential medication list, and it's not available 25% of the time. But after war, both are not available, and patients have to brought it from abroad in higher prices. In Chad, hydrocortisone rarely exists, and it costs $20 for the box of 30 tabs, and fludrocortisone doesn't exist. So as you can see here, the hydrocortisone and fludrocortisone is not readily available in many of the African countries. Another study from other group to assess the fludrocortisone and hydrocortisone in children in EMLc region. As you can see here that the oral fludrocortisone is sometimes available, but it's not included even in essential medication list in many countries, while the situation of hydrocortisone looks a little bit better, but it's also not available in many of the countries. So what are the practical solutions that have been taken by different countries? They either take it from private pharmacies or import it from abroad. And the absence of fludrocortisone, more salt is added and increase the dose of hydrocortisone by 25%, but it's not well studied. And in the absence of hydrocortisone, prednisolone seems the relatively available and affordable option, but it has many side effects especially on small children, where it affects the growth. So in summary, more efforts need to be put into raising the awareness and securing medication to prevent mortality. Hydrocortisone is available in some African countries, yet it's not really available in most of the time. Even when available, it's not affordable in many countries. And fludrocortisone is not available in most of the African countries, and it has to be brought by parents or private pharmacies in very higher prices. And we need a global policy decision is needed to reach a stable supply and save lives. So here I want to thank two organizations like ASPI and CLAN, who they are trying to raise the awareness about the CH and similar condition. And in ASPI, which is African Society for Pediatric Endocrinology and Diabetes, we have the ASPI-CH DSD Research Network Group, where we are trying other alternative to see the situation of CH and DSD care in African countries. Thank you very much.
Thank you so much, Dr. Salwa, for the wonderful presentation. It was very informative. I would now like to introduce Emma Clackman, and I hope I'm pronouncing the last name right.
Hi, Samiha. Thank you so very much. Just checking you can all hear me okay. It's great, wonderful. It's wonderful to be here with familiar and new faces. I feel that we're all in solidarity, but I must say that I come to my presentation with a level of somberness because we keep hearing the same chorus: not affordable, not available. And unfortunately, this is a common reality across the childhood NCD space and NCD space at large. But I'm here today to talk about what keeping children safe who live with type 1 diabetes, what that looks like in low and middle income countries. So thank you, Samiha, for the introduction. My name is Emma Clateman. I am representing Life for a Child. For those who are not familiar with Life for a Child partners with local providers, including Dr. Salwa Musa, who just spoke, to keep children with type 1 diabetes safe today and help governments and local capacity and improve that to help build systems for tomorrow. Life for a Child currently supports well over 60,000 children and young people through around 100 local partners in over 50 countries. And I'd just like to anchor that scale. The type 1 diabetes index estimates that there are roughly 9.5 million people living with T1D globally in 2025. Now, the T1D index has this concept of missing people, those who should be alive today, but who have died prematurely due to non-diagnosis or lack of basic care. And of that 9.5 million people living with T1D globally in 2025, there are 4.1 million missing people. May I have the next slide? So what does safe care for a child with type 1 diabetes require? What does it actually require? So safe survival depends on there are more, but these are the core 4 essentials that are needed every single day at multiple times a day. The first is reliable insulin. The second is daily blood glucose monitoring, education and empowered young people and families, and skilled health care professionals with continuity of care. That is the non-negotiable package. Next slide, please. So what has progress looked like? Well, I opened my segment saying that, I come to this with a somber tone, but actually in the last 10 years, and especially the last 5 years, since the global community marked the 100-year anniversary of the discovery of insulin, we have seen real gains in many low and middle income countries. And the situation is improving. What we're seeing now is that there is earlier diagnosis and visibility. The T1D index, as I mentioned at the start, has made the burden more visible at the country level, which in turn is catalyzing policy conversations that simply did not exist a decade ago. Secondly, there are more children who are receiving treatment and learning how to manage their diabetes at home and find paths toward empowerment. And that means that they are alive and more keep growing. we see that global modeling is showing the diagnosed T1D population rising due to improved survival and aging, especially in lower income settings. And this is a sign that children are being found and living longer. Thirdly, clinical capacity in supported centers that receive Life for a Child support has grown. In sites we're seeing where partners focus on pediatric diabetes, local skills, structured education, and continuity of care, we see things improving. Life for a Child's role includes training, resources, and mentoring with local teams. And of course, Life for a Child is not the only entity pushing progress forward in this space. There are many other groups, including Changing Diabetes in Children, PEN+, Action for Diabetes, and of course, CLAN. And also on the broader policy scale, I think it's absolutely worth noting the Global Diabetes Compact targets to 2030, which includes 100% access to affordable insulin and blood glucose self-monitoring for type 1 diabetes. And really, this gives us a concrete benchmark to advocate against. Next slide, please. But for all of the progress, I must say that at times this progress feels, we feel the fragility of the progress, I'll put it that way. And I say this because despite the gains, we see that insulin availability and affordability are still very uneven across LMICs. Multi-country studies and reviews show poor availability and out-of-pocket costs that very quickly can push families into crisis, especially outside capitals and in rural areas. I think it's also worth noting, and we've been jumping up and down about this for years, of course, insulin is the cornerstone of type 1 diabetes management, but test strips are what's needed every day, multiple times a day, to make sure that insulin therapy is safe. But at the same time, test strips are even less protected in budgets than insulin. WHO's 2023 Essential Diagnostics List, Life for a Child, and the NGO FIND Diagnostics based in Geneva had to explicitly advise personal use meters and strips for home self-monitoring of blood glucose. And this is a signal that access has lagged in this area for many, many years. And then on the topic of glucagon, emergency treatment for severe hypoglycemia is underused and often hard to obtain. May I have the next slide, please? So I just want to ground this in the work that Life for a Child does. Our bread and butter work is insulin support, meters and strips, pens and needles, HbA1c and complication screening, education for families, camps, training and mentoring for healthcare professionals, and research. But this is always done through local partners. You will never go to a country that Life for a Child supports and find a Life for a Child center. We always work through existing champions. I think it's fair to say that Life for a Child has helped to empower those local champions to transform pediatric diabetes services by strengthening local teams, helping to standardize education, and sustaining supply flows. But insulin strips and glucagon still at the systemic level, access to these critical components of care remain majorly unresolved issues. And to fix this requires conversations on the macro level and national financing and procurement, and not just support projects alone. The next slide, please. And just to provide some context for where Life for a Child works, I'll let you take a look at the map and take that in for yourself. Slide again, advancement. And I mentioned this a couple of slides ago, but I think it's worth saying that glucose monitoring really it should be viewed as a pressure point. And glucose monitoring is the system pressure test. Without strips, as I've mentioned, insulin dosing it's simply not safe. Now, the WHO 2023 EDL explicitly advises personal use meters and test strips, but the way that this has trickled down into national procurement, it's hard to say how this has advanced. I think, the development of national essential diagnostics lists on their own, that's another advocacy issue in and of itself. The next slide. And then on education and skilled care, these are equally essential. Supplies alone, insulin and test strips, they don't deliver safety, and families need practical self-management education, and clinics need trained pediatric diabetes providers with continuity. And this is a core contribution of Life for a Child. The next slide. Now, many others in the ecosystem are contributing and will continue to, but governments must embed insulin test strips and pediatric expertise in universal health coverage financing and workforce plans. Next slide. And I think I'll wrap up here and say what still needs to move by 2030, four pragmatic shifts. The first would be on insulin and test strips and universal health coverage packages within countries. These need to move both into publicly funded routine benefits with realistic monthly strip quantities for children, not just one test strip or 2 test strips or 5 test strips a month. This needs to be in line with guidance from ISPAD, which is the International Society of Pediatric and Adolescent Diabetes. The monthly strip quantities need to be evidence-based. Secondly, on workforce and education, we must move towards standardizing pediatric diabetes training and ensure ongoing family education is available in every supported clinic where young people are receiving care. We need quality procurement of blood glucose meters, test strips, insulin, HbA1c supplies, and glucagon. And finally, on evidence and accountability, Life for a Child has done work tracking universal health coverage as it relates to type 1 diabetes for young people in countries within existing health systems benefits packages. And we are embarking on future work developing a live dashboard looking at availability, affordability for diabetes care in countries. And this will be called the Life for a Child Global T1D Equity Repository. And I'll just go to the final 2 slides. Type 1 diabetes is survivable everywhere. With insulin strips, education, and skilled care reliably in place, it is survivable everywhere. And that is exactly what the WHO 2030 target for type 1 diabetes demands. Life for a Child keeps children safe today while working with the global ecosystem to make that safety systemic and permanent. Final slide. Our North Star is simple and it's shared. No child should die of diabetes. Thank you.
Thank you so much for your presentation, Emma. I'd now like to introduce Dr. Isaac Adam.
Thank you very much for this opportunity to share some thoughts about access to hydroxyurea for the treatment of sickle cell disease in Africa. presenting on behalf of the Global Sickle Cell Disease Network and the World Coalition on Sickle Cell Disease. Next slide, please. So sickle cell disease really epitomizes how one disease is disproportionately centered in Africa. So you're looking at a cartoon of global burden on newborns according to scale. And as you can see on the left, that 3 countries, Nigeria, DRC, and India, constitute about 50% of the world's burden. And the left really maps what is on the right, where the poorest 1 billion people live. So where the disease is, the burden is heaviest, is where the resources are least available to treat this disease. Next slide, please. The global burden of disease 2020, the 23 publication revealed that the global burden of mortality is centered in sub-Saharan Africa. And on the right is showing the trends in mortality from the year 2000 to 2020 for those under 5 years, those under 20 years, those between 15 and 49 years. And as you can see, both cause-specific mortality and total sickle cell disease mortality, which is 10 times that of cause-specific mortality, increased over this period from 2000 to 2020. And this was most pronounced in sub-Saharan Africa, which is the top shaded area. Next slide, please. Hydroxyurea is a very well-known drug. In fact, it was first synthesized in 1869 by 2 German chemists. And so the drug is more than 150 years old. But it wasn't until 1998 before the US FDA approved hydroxyurea specifically for the indication of sickle cell disease in adults. The European Medicines Authority did theirs in 2007 for both children and adults with sickle cell disease. The US FDA approved it for children in 2017. And hydroxyurea has been listed on the WHO Essential Medicines list since 2011. So a drug synthesized 150 years ago is still inaccessible for the treatment of sickle cell disease for the majority of people living with sickle cell disease in Africa. Next, please. Its clinical benefits are overwhelmingly confirmed, both in randomized clinical trials, in adults, in the developed world, and in children from the age of 9 months to 17 months, which is the Baby Hug study and the multi-center study on hydroxyurea, which is the MSH. In all parameters of measurements of outcomes, both pain, acute chest syndrome, dactylitis, hospitalization, and transfusion requirements, this drug has been shown in double-blind placebo-controlled trials to be effective. On the right, we're seeing the results produced in sub-Saharan Africa in the REACH trial in 4 countries in sub-Saharan Africa, again showing the same impact with even evidence of reduction of malaria infections and all sickle cell-related events. Next, please. However, the quantities of hydroxyurea needed to treat sickle cell disease, this is just estimating based on a dose of 20 milligrams per kilo on the average, that to treat 1 million new patients with sickle cell disease, we'll need to be producing at least 400 tons of hydroxyurea. This requirement of production is way above what is available on the world market now. Next, please. There are 2 opposite worlds. Hydroxyurea has been approved for treatment of myeloproliferative indications for many, many years. And this was what has driven the world production of hydroxyurea. They come in 500 milligram capsules. They are registered worldwide for the treatment of myeloproliferative disorders. There's increasing demand in all countries. The formulations are fixed and the market is very mature. But for sickle cell disease indication, there's no accurate estimation of the of the volume that is required. And in Africa, we think less than 10% of the patients who need hydroxyurea are on this medication. Because there's no systematic screening or diagnosis, the entry point to accessing this drug is limited in many countries. There's need to increase production capacities. Few countries have registered the drug for this indication, and there are no pediatric and low-dose formulations to be able to address doses in the pediatric age group. So enormous investments are needed to really develop this market and expand it to be able to meet the demand that is out there. Next, please. To illustrate this, I want to present two case studies, one in Ghana and two in Nigeria. Ghana case study reflects the period 2014 to 2023, in which there was a public-private partnership between the Ghana government, the Sickle Cell Foundation of Ghana, led by the late Professor Henry Frimpong, Novartis, and an active pharmaceutical ingredient supplier to really deliver hydroxyurea as a disease-modifying treatment to a large number of patients, over 4,000 of patients. So it was registered in the country, and in 2018, a policy decision was taken to cover the medication under national health insurance. This has been an exemplary model of how multiple partnership, particularly public-private partnership, can really deliver. However, up to this point, supplies can be frequently interrupted and uptake is limited only to a few urban centers. The case study in Nigeria really illustrates the challenge in expanding demand for hydroxyurea. Nigeria is fortunate to have a local industry that formulates hydroxyurea. This has been done since 2021. However, this industry plant actually produces only at 1/4 of its capacity because the health system challenges without adequately trained health professionals to prescribe the medication and to administer and monitor it, and low level of patient awareness about hydroxyurea's effectiveness, the lack of insurance coverage, and no coordinated government leadership to ensure full procurement and lower prices for this commodity is not meeting the demand that is required for this production to be at full capacity. So here you have capacity to produce, and yet the demand for the medicine is so low because of the systemic challenges. Next, please. So what are the challenges facing availability? There's no African manufacturers of hydroxyurea at all. The drug is mostly imported from outside. And the two formulators that I've identified do not make the active pharmaceutical ingredient. And none of these formulators have WLA status, WHO listed authority to produce these formulations. In Nigeria, the cost is about $3 per month for a child. And in Senegal, only recently, they are producing at $2.7 per month for a child. Registration for sickle cell indication is not universal in sub-Saharan Africa, but I have to say that over the last 10 years, several more countries have listed hydroxyurea as an indication for sickle cell management. The World Health Organization placed hydroxyurea on its EML in 2011. As yet, an expression of interest to qualify hydroxyurea for pre-qualification has not yet been released, but this is something that needs to come online so that access to this medicine and manufacturing of quality assured hydroxyurea can be initiated, particularly on the continent. So as I speak, there's a global shortage of hydroxyurea to meet the dual demands of myeloproliferative indications as well as sickle cell disease. And supply chains are still posing enormous challenges to access, particularly in Africa. Next, please. So the barriers are availability, affordability, health systems challenges of screening and diagnosing, laboratory testing, guidelines availability and insurance coverage, skilled health professionals who know how to prescribe this medicine and monitor it is also a challenge, awareness among people with lived experience to demand this from their healthcare providers, and sometimes patient transportation to health centers, which are the only centers that can prescribe this medicine, can pose a major barrier. Above all, we need government leadership and ownership and political commitment to address this disease, which has its highest burden on the continent. The international community needs to work collaboratively, public partnerships, as was the example in Ghana, the WHO, African Union, African CDC, the African Medicines Agency, which I will talk about in the next slide. Next slide, please. So there's been some developments. The establishment of the Africa CDC is a major opportunity to coordinate activities among African governments and to get them engaged to focus on this neglected disease. The African Medicines Agency will be a major asset in regulating quality assured hydroxyurea to make sure that those who produce this drug do not have to do multiple registrations across the continent. National regulatory bodies are all working towards achieving maturity level 4 or WHO listed authority. And when this happens, there'll be increased numbers of local formulators of the medicine, and indeed, actually, local manufacturing of hydroxyurea in Africa, which I think should be the ultimate goal, to be able to lower costs and break the barriers of accessibility. On the WHO side, pre-qualification for hydroxyurea will be a major asset for future manufacturers and producers for both adult and pediatric formulations. WHO Sickle Cell Disease guidelines are expected soon, and that will be a book boost to healthcare providers to learn how to prescribe hydroxyurea and to know the indications of using this drug. The guidelines are being developed, and research consortia in Africa, including Sickle in Africa and Sparkle, are all emerging and developing guidelines and training healthcare professionals to be able to prescribe hydroxyurea. Country guidelines in Ghana, Kenya, Tanzania, Uganda, and others, as well as French-speaking Africa, have all now been developed. What is left now is to use digital tools to train healthcare professionals and to ensure that the number of prescribers of these medications increase, as well as increasing awareness among the patient population. Next, please. In summary, 75% of over 500,000 children born every year worldwide live with sickle cell disease in Africa. And less than 10% of these who should be regularly treated with hydroxyurea are on this very effective medication. As a result, morbidity is still high and mortality is way above what it should be. Several barriers exist to accessing this drug, and we have identified some of them, which requires concerted, multi-stakeholder, trans-sectorial partnerships to be able to bridge these gaps. Unless we do this in an accelerated fashion and with combined efforts, the goal of 80% by 2030 will not be achieved. And I believe we must act now, and we have all the tools to enable us get there. So let us get together to address sickle cell disease in Africa. Thank you very much.
Thank you so much, Dr. Thomas, for the presentation. It was very informative and inspirational. I would now like to introduce Lorenzo Mojo.
Thanks. Thanks a lot. I'll share my slides. I hope you can see. And thanks a lot. Thanks a lot for the invitation. And it's a pleasure to be here with you and to share some reflections on is the access to medicines for children. And I'll give you some reflections along a clinical arc. I'll cover like a general overview, and then I'll move to rare diseases, childhood cancer, infectious diseases, and some work around the formulations that are needed for children. And I also I'm seeing somehow that we share or we're part of a chorus in which we somehow are identifying several gaps across the different diseases. And I'd like now to go to the potentially the origins of these problem and in reasoning on which medicines for children are prioritized. And it's unclear when you go at the country level, when you go on national EML, which medicines for children are prioritized. Out of 150 national EML, 22 have medicines for children in terms of formulation identified. And the problem is that somehow where it is more striking, these lack of attention is not in low-income countries, but is in high-income countries. That in this case are not giving somehow the example, are totally ignoring what should be the medicines for children to prioritize. And that may have some reflections then in globally, right? So there is substantially little evidence that the countries are implementing in adequately medicine policies for the youth. Let's reason on, you talk about asthma, sickle cell diseases, and some also like a rare conditions. So let's see what happened with the rare diseases, right? Over the past 5 decades, substantially, the ML started to increase the number of medicines for rare diseases. Theoretically, if a disease is rare, it should be easier to cover the need, right? We are talking about less patients. And we can see that is also the innovation, right? The new treatments are highly effective for rare conditions that were then launched in the different markets and then uptaken by the ML has been increasing for like 2% in 1977 to almost 15% in 2021, right? So the ML is moving with incorporating these innovative medicines. So one of the example is the Trikafta for cystic fibrosis that was added in DML in 2025, but only 30% of the patients with cystic fibrosis globally have access to these medicines. I'm not even talking about the triple, but about all the ivacaftor, right, which is a part of the backbone therapy for cystic fibrosis. Even if the medicines are clearly like a game changer, so we on one side we have 80% as a bold goal that you have mentioned, and even when we have few patients to be treated, we are about like 30%. So like it's a 50% delta. I'll now move to the childhood cancer to say that again, to go back to these 80%, right, is DMLs for children is including 90% of the medicines that are considered the most important by pediatric oncologists around the world. So DML on one side is including the medicine that like the oncology are thinking that are the most important. And these medicines can basically provide a benefit that is 80% survival in high-income countries, but is only 20 to 30% in low resource. So, and again, as we don't have a strategy around these medicines, it's also possible that key medicine like vincristine or acitarabine are not available, right? We have shortages, or like that is not only low-income countries, also like asparaginase, for like is another example of shortages that we have in across all countries, irrespective of income. And then it's producing something that is really striking because DML and also DML for children cumulates also like the new medicines, right? For instance, this year we listed blinatumomab, which is a medicine that is curative in case of leukemia in children, but at the same time is not available and not affordable yet in most countries. And these 80% that we like to reach then it's not only a problem like it's 2030, like it is as a potentially a too ambitious goal, but how many years more will take to have drugs like blinatumomab available around the world. I'll turn now to infectious disease also to show like is the double phase. Now I'm talking about the antibiotics. And what we know is that even in sub-Saharan Africa, for instance, when we go in primary care facilities and we check about the availability of antibiotics, about 50% of the facilities would have like the key antibiotics, like gentamicin to basically try to cure neonatal sepsis, right? So that would be a life-saving antibiotics. So 50% is slightly better than what we have for cancer, for what we have for rare conditions. Still 30% below the 80% goal. And at the same time, what we know is that 60% of the children, even again in sub-Saharan Africa, would be getting like an antibiotics at the end of their visits that would be inappropriately prescribed. And all treat the almost all children when at the age of 5 they already took 5 courses of antibiotics during their life. So in that case, we see that there is even somehow like an excessive medicalization, even where like important antibiotics would not be available. And that is producing the resistance. And we know that 1 in 5 children under 5 would be dying because of an AMR-related death. It's not only a problem of not having access to the medicine, but it's also a problem of not having the right medicines in terms of the formulation. So like is a WHO, there is an initiative that is important, is the GAP-HF, the Accelerator for Pediatric Formulations, to identify and to try to develop then medicines that are targeting the children, right? We have tools to try to create the target product profile, and then also not only the formulation, but also to try to have the drug optimizations, meaning which dose should be given to the children. And it may be surprising, but even medicines that have been used for decades, right, is in the case of antibiotics, more than 70 years, right, is for like a very common antibiotics like amoxiclav or azithromycin, we still have problems in the dosing. The dosing like is how like would be the best dose in terms of for like milligrams per kilos. To not talk about more like newer antibiotics like cefiderocol. So we also need to have a research pipeline that is targeting children, at least for those medicines that are the most important. So the core principle, children's medicines are not simply smaller version of adult medicines. I think that is important that we continue to have attention to the medicine for children. We insist because I think the message has not yet passed at the political level. There is some attention potentially in Geneva, right, or in New York, but like outside this context, still like the implementation and the dissemination has yet to become true in other capitals. I would like also to conclude to say that in 2027, it will be the 50th anniversary of the first EML, but by chance, it's also like as in 2007, it was the first EML for children, it is also the 20th anniversary for the EML for children, basically. So, and this should be, I think, is an important milestone to remind to countries, to policymakers, the importance of revise their national EML to include also the medicine for children, to make these like giving more dignity, including also the formulations of like for children, to reaffirm the importance of a tool like a DML as a global standard, so we can better measure the alignment between the national list and the WHO EMLc, and then to renew the discussion on the role of medicine pricing, right, is including the orphan drugs, but also the cell and the gene therapies that may be, again, very important in the near future, particularly for genetic disorders and disease for children. Thanks a lot very much. It was really, really nice to stay with you. Thanks.
Thank you so much, Lorenzo. We will now take the time to present about Carmen Oste, but because she cannot be here with us today, we will have Kate presenting her slides on her behalf.
Thank you so much, Tara, and thank you so much, Lorenzo, for that really excellent presentation, and to all of the speakers as well. A special thanks to those fighting the time zone battles. Carmen Oste is an incredible leader from the Philippines. She's the founder of Cancer Warriors Foundation, the mother of a survivor of childhood cancer who has been passionate about advocacy around childhood cancer ever since. And she has a previous past president of Childhood Cancer International and works closely with all the leading childhood cancer champions around the world. And she is also the co-chair of Mates for Kids, and she shared she's such an inspirational, strategic thinker, and she's shared some really, I think, excellent reflections that I'll just do my best to speak to. Next slide, thanks, Tara. Carmen shared some reflections on gaps to access to medicines, noting, of course, that the childhood cancer community have perhaps made perhaps equal with childhood diabetes, but more gains than any other childhood NCD groups, I think, in this space. Despite the might of the childhood cancer universe, and there's St Jude's Hospital, which obviously does great work, but they've also been working with WHO and PAHO, UICC, IDA, ATOM. There's so many big stakeholders here, but still access varies at the country level around the world, and pediatric formulations, as Lorenzo just spoke to, are frequently missing, and there's unsafe dosing as a result. WHO has convened an experts advisory board to review pediatric formulations for childhood cancer drugs, so there are some real positives on the agenda there. Next slide, thanks, Tara. I think this comment, listing a medicine as essential is not enough if it never reaches a child in the right formulation at the right time. And that's really the message that we've seen echoed across all the presentations today. Thanks, Tara. The next point that she wanted to speak about was affordability, and just really acknowledging the way that needing to access medicines just bankrupts families. Where there are insurance and UHC benefit packages, they can make a real difference, but essentially spending can be catastrophic for families. Thanks, Tara. And if we're all talking about this moving forward, Carmen makes the point that essential medicines for children must be treated as a public good and not a private household burden. And that's a really powerful statement, I think. Thanks, Tara. Next, she wanted to highlight fragile supply chains and over-reliance on imports. And certainly today in a few of the presentations, we've heard about the power of local manufacturing. Where there's really strong dependence on single suppliers or imports. And we saw through the COVID pandemic the situation where you have lack of access, particularly for conditions such as diabetes and congenital adrenal hyperplasia, where children need uninterrupted supplies to survive. There are real risks when supply chains are fragile. So she really highlights the need for regional pooled procurement, buffer stocks, and incentives for local regional manufacturing of pediatric formulations. Thanks, Tara. Next, she wanted to talk about quality and safety concerns and the way they disproportionately affect children, particularly where there are substandardized or false or fake medicines, dosing errors where there aren't pediatric formulations, or weak pharmacovigilance systems. She says, for children, poor quality medicines are not just ineffective, they are dangerous. And indeed, I was in communication with a pediatric endocrinologist working in Chad in Africa this week, and he was talking with a family who were looking all over their town for medicines, and in the end they bought some at great cost only to find out they were fake. So this is impacting families every single day. Next slide, thanks, Tara. Vulnerable and marginalised children are systematically left out, and this is where we've all been touching on equity and inequity, and our focus has been on children in lower income countries. First Nations communities, Indigenous children in particular, also need help. But I think it's the very nature of these chronic long-term conditions that even if a family isn't impoverished just at the start of their journey in a low-income country where they don't have UHC and financial protections, spending money on a daily basis to keep their child alive, they really do tend to shift into those financially challenged situations. So the equity lens is vitally important. Migrants, refugees, internally displaced, undocumented, Indigenous children must be explicitly named in any global commitment that we have moving forward. Next, and a governance gap is so important. National medicines policies often focus on adults, prioritise communicable diseases, and treat paediatric NCDs as low volume, high cost outliers. And I think that Lorenzo's comment that kids' medicines are not simply smaller version of adult medicines is just really powerful. Thanks to the next slide there. Carmen's sense is that this is a resolution-worthy moment, that perhaps together we can come together as childhood NCD communities and take this further. Lorenzo pointed out that 2027 is a really important year with the 50th anniversary of the EMLc and the 20th anniversary of the 50th of the EML and 20 of the EMLc. So we will be sharing a report from this event today and liaising with the stakeholders who've been speaking and some of the community members who weren't speaking today. We're sharing links in the chat with messages from epilepsy communities and other communities who also really want to see progress in this space. So I guess in closing, this has brought us to the end of the agenda, and I just wanted to thank everyone who's participated, particularly from all the different countries. We've had so many different regions participating today, and I feel like we all have this shared, just back to the last slide there, Tara, sorry. I think that the speakers today have really highlighted there's a need for a global commitment to improve access, availability, affordability, safety and quality of essential life-saving medicines for children with NCDs, especially those from vulnerable and marginal populations. I think we've heard lots of points today about things that we could include in a resolution moving forward. Thanks, Tara. On to the next slide. I think Emma's point that we need to move from survival to security was really, really powerful. And Carmen has listed some points here that she thinks could go into a resolution on access to childhood NCD medicines. But I also really want to highlight just how powerful it's been for me. Clan has been working in this space for 20 years. But today I heard so much from other speakers, and I think we can really have the chance here to learn from one another. I've just been writing down things that I've learned from people today, from Leith and the asthma community, just the power of patient stories. Perhaps we can get more patient stories out there and share those a little bit more. From the T1 community, the T1 index, the work that T1 community, T1 diabetes community and Life for a Child are doing with data is really fantastic, and the shared dashboard that they're developing just sounds like something all childhood NCD communities could really benefit from. The work that ASPE are doing in Africa around regional mapping of data is really powerful because every single country is experiencing challenges But when you have a regional authority like ASPE, the African Society for Pediatric and Adolescent Endocrinology and Diabetes, come and do some mapping like that and show that actually this is a regional issue. It's really powerful. We heard about the importance of NEMLs, National Essential Medicines lists, and diagnostics lists, the importance of people living with NCDs and childhood NCD community champions, the importance of local manufacturing, the sickle cell disease communities doing incredible work, leading the way around pre-qualification, and of course the T1 diabetes community have done some great work there as well. We've heard about the importance of policy, life course approach, the vital role that caring healthcare professionals play, and clinical guidelines. I feel like today has just been an incredible learning opportunity. So as a next step, our wonderful team led by Tara and Samir will be putting together a report on today's event, and we'll be sharing that with our speakers and then launching that at the UN Women's CSW 70 event that's in March. Our team will be attending in New York in person. We'll also launch it online. And we really hope to continue this journey with all of you into the future. If there are any people here who are going to be at the World Health Assembly in Geneva in May, we'd love to connect with you in person and keep those conversations going. Otherwise, we'll keep going in virtually and online as well. So really, that's all the closing statements, other than to thank everybody for your help. Just back to that last slide and that last comment from Carmen there, I think children with NCDs cannot wait for market forces to notice them. Essential medicines for children must be treated as a moral, public and global responsibility. Thank you, Carmen, for your words. Thank you to all of our speakers. Onwards and upwards. I think 2027 is looking like it's going to be a really big year. Lorenzo has set us all a challenge, and our team will be in touch again. And thank you for watching, and thank you, Tara and Samia. You're fabulous. Just to let people know, if you know of any congenital adrenal hyperplasia communities that need funding to do community development efforts, our Round 8 grants are now open. That can be on the Mates for Kids website. So just a little plug there for community development. So thank you, everyone. We look forward to staying in touch, sharing the report, and thank you all for promoting this event on social media. And again, thank you to everyone who stayed up at horrible hours of the day to make today such a success. Thank you, everyone. Bye-bye. Bye.